Oh, hang on, I'm in preview. Oh. Hello again. It's great to see you all getting involved in what the platform has to offer, and good to see so many familiar faces from this morning's sessions. Thank you for staying with us. Infection control is our fifth and final panel debate, well, of the day, but of also 2021, actually. Whilst the importance of safe, clean environments should never have been overlooked, this past 18 months has taught us we can never overlook the importance of preventing the spread of infection again. The importance of a clean, safe environment for all aspects of healthcare should be an experience I'm sure we can all relate to. When designing new facilities or renovating older facilities, we must see collaboration between architects, builders, healthcare professionals, and infection management teams. This in turn should help towards lessening the spread of healthcare associated infection. We also mustn't forget soft resources when investigating infection control in estates. We want to consider the critical roles that healthcare buildings and design play in facilitating good infection prevention and control, IPC practices. So here to discuss this with me are the brilliantly suited panel: Professor Michael Borg, Head of the Department of Infection Control at Mater Dei Hospital in Malta; Linda Swanson, Director of Nursing Infection Control for Salford Royal NHS Foundation Trust; Laird, Head of the Infectious Disease Research Group at Montfort University; and John Hines, Global RD&E Director for SC Johnson. Now, ask any questions you may have for our panelists and help me make it a full conversation. So don't be shy. If you've got a question to ask, we've got fantastic guests. Use our live Q&A function, which you'll find on the right-hand side of your screen. So very good afternoon to all my panelists. A couple of familiar faces there with Linda and Katie. I know we've spoken before. And a treat to have Michael on board from Malta. I don't think we've had a guest from Malta before, so that's nice. John, I'm going to start off with you, if that's okay. SC Johnson Professional is a member of POPS, the Private Organisations for Patient Safety, a collaborating partner of the World Health Organization. Can you start us off by explaining to us the role that POPS plays and how's the group been able to support hygiene protocols in healthcare during the pandemic that we've all been through?
Thanks, Helen, and thank you very much for the opportunity to join today's panel. Yes, as you say, we're a member of the POPS, Private Organisations for Patient Safety for Infection Control, which is a really useful collaborative between industry and the World Health Organization. Broadly speaking, over the years, the agenda and the focus for POPS is really in two places. In the first instance, it's providing a bridgehead between the World Health Organization and frontline healthcare around communication for hygiene best practice, and specifically the World Hand Hygiene Day on the 5th of May, which of course we support along with our peers in the infection prevention industry. And then secondly, we spend some time with the World Health Organization and again with our peers, discussing and trying to drive forward best practices for infection prevention. So that would be scientific research agenda items where we don't compete, but rather we collaborate as an industry to try to raise best practice, understanding when and how, and specifically to what effect to deliver hand hygiene in hospitals, helping healthcare workers deliver hand hygiene more effectively and reduce infections. Through the pandemic specifically,
I was just going to say, never has it been more an important time then through the pandemic.
Absolutely. And some of the things that we've got up to in the pandemic would be, in the early days of the pandemic, really trying to understand how international supply chains work and helping the World Health Organization support us in continuing to deliver high quality hand hygiene products in the middle of course, that supply crisis that happened early in the pandemic. And then coming out of the pandemic, one of the things that I think we all recognize was how important it is to be able to communicate the best products to use in certain situations. And so again, we're working as a group to try to improve how we can communicate which products work against which pathogens, how products should be used, how products should be selected. And of course, just equally importantly, when to avoid using the wrong products, let's say. So it's a really useful group. And I think we have to commend the World Health Organization on their collaboration with industry in this area.
Michael, it really is lovely to have you joining us from Malta. Tell us a little bit about your hospital and your COVID experience.
Yeah, well, thank you for the invite. I mean, it's really a pleasure to participate here. I lead an infection prevention team in Malta today, which is the main hospital in Malta. It's a 1,000-bed facility. So you can imagine with the COVID pressure that we had, especially last year, we had numerous challenges in terms of hospital design. And I think if I were to take home messages, first of all, I think we realize that one of the most important aspects in estates construction nowadays is the need to upgrade your intensive care facilities effectively. We did manage to increase our intensive care beds significantly, which was a godsend, but the design wasn't ideal because, like most people, we ended up sort of cannibalizing recovery rooms in operating theaters. And it's okay in the sense that you have all the facilities you need for intensive care, but then we started to find the same challenges that you now read in the literature. You know, when you have a recovery area which is not designed for this type of purpose, you then come up with issues like donning and doffing. So we ended up with staff having to don before they go in because we just closed out the whole area. And then they stayed for 2-hour shifts working there. But then when we started to do root cause analysis of issues there, we realized that we had major problems because although the protocols will demand changing of gloves, for example, between patients, when you have an open plan Nightingale area, human factors come in and it makes it very difficult. So I think if we have learned nothing, it's that and the need for single rooms. Our hospital isn't too bad in terms of single rooms. It's a reasonably new build, 2007, so it's less than 16 years old. And we have quite a substantial number of single rooms, but I think the way infection prevention is going, I'm pretty sure we'll see 50, 60, 70% single room hospitals in the near future, because that's what we learned from COVID.
Let's bring Linda into the conversation. Linda, does some of what Michael's saying resonate with you, and what was your experience like in Salford?
Oh, absolutely. So we are a multi-site organisation. So we've got 4 large acute hospitals and community settings. So we had exactly the same experiences as Michael, but kind of magnified across sites. And I think, you know, one of the key factors Michael's speaking about, how important estate is we can actually design out poor infection prevention and control, practices, issues with some clever design. And it's really important, I think, that people actually look at their estate, and that actually this COVID pandemic has been an opportunity for us to learn. And actually what we've got to do now is build back better. We can't just keep repeating design errors. We need to build back better. And by that, the points Michael's touched upon, increasing the space, increasing isolation capacity. Isolation capacity is key, but there are other underlying fundamental issues that we can all do something about quite easily, and that's things like improving ventilation in the healthcare buildings. Such a vital component of good IPC practices. In fact, throughout this, as everybody knows, the beginning of COVID was largely an evidence-free zone. So it was really important that we tried to understand as much about it as quickly as possible. And on one of my hospital sites, there was quite a significant outbreak of COVID. And when we mapped these cases using kind of epidemiology, we were able to pinpoint that if a patient was in a certain area, they were 3 times more likely to develop COVID than some other patients. And so we began to look at actually why that would be the case. And ventilation played a key part in this. So old style buildings with multi-occupancy bays, as Michael spoke about, Nightingale wards are very difficult. Nightingale walls were originally designed so that the tops of the windows would open to provide ventilation. But we've come along in our modern day era and covered it with UPVC double glazing, and the windows don't open to stop patients from having accidents out the window, shall we say. And so we've done a lot to actually reduce the ventilation in buildings. So my key advice is that to go back around, re-look at it, and actually look at those simple things that can improve the environment really quickly.
And perhaps risk assessments, maybe, I would imagine. Katie, finally getting round to you. I'm sure you've probably got things to contribute from things our other panelists have said. Linda was talking about ventilation there, and I know that you always have a lot to say about the role of textiles in transmission of infectious disease. But do feel free to respond to, you know, any points you want to pick up on from our other panelists first.
Infection control purposes, like the windows opening that over the years have been reduced, are easy fixes, aren't they, Linda? Things that can be done quickly without redesigning the hospitals. But as you said, textiles is my area of expertise, and we have shown that the textiles, particularly healthcare uniforms in the UK that are domestically laundered, the infection control risk is at the point to which it goes into the washing machine, because actually the removal of SARS-CoV-2 from textiles via the washing process, a bit like the hand washing process, it works. But it particularly in the UK, and I don't know, Michael might be able to tell us what the policies are in Malta, nurses were taking their uniforms home to domestically wash, apart from those on the COVID wards where scrubs were supplied and they're industrially laundered. And that point of leaving the hospital to going into the washing machine is where we noted that the highest chance of infection control risk is, because, for instance, coronavirus can survive on polyester for up to 72 hours and transfer to other surfaces. So it'd be interesting to hear from Michael whether your textiles, your nurses' uniforms, generally in Europe, they're in-house or industrially laundered.
No. I mean, our policies, remember, we have, most of us will train in the UK. So historically, we always look west and turn, and we have practically the same policies as you have, like you, mainly for, or at least in addition for psychological reassurance. We were relatively liberal in giving staff, especially in the respiratory wards and the COVID wards, scrubs. So that solved a lot of issues, but all the rest would launder them at home. We follow the HIS guidelines in terms of laundering of uniforms. It's the, I'm sure you've seen the policy that Peter Hoffman had established quite a few years ago. We basically tell them to launder it at 60 degrees. I mean, to be honest, we haven't had too many issues. I mean, we do have a very short guidance, in the sense that listen, take them in a bag, use a cycle just for the uniforms, put the bag in the washing machine, gently pull out the bag and leave the laundry there, and then wash it. The other thing that we have over here is we have sun relatively in abundance, though that wasn't the case last week, I can tell you. God, a whole week of rain, never had this. Definitely global warming here. So that's another intervention. So most people will hang out the laundry outside. I mean, to be honest, we don't think we had major issues with laundry. And what Linda's saying about the ventilation, I would definitely say myself. I mean, thankfully, as I said, it's a relatively new build, so it wasn't that difficult to adjust ventilation, to increase air changes, even shift from neutral to negative pressure in some instances where we needed it. But I can imagine if it's an old hospital, there would be massive challenges there.
Absolutely. John, I know you were nodding through everybody's answers there. Let's just ask what advice or guidance that you can give to improve current PPE protocols and how these can be implemented by IPC and estates and facilities to reduce the hospital transmission of COVID and, of course, pick up on any thoughts that our other guests have said.
Yeah, well, you're right. I mean, I was nodding along. I have to say, Michael, first of all, where I live, there's no lack of rain, so that's something we certainly can supply. But yeah, it strikes me that I think the question you've asked is really relevant to the conversation that we've had. That what I'm drawing out of it from everyone's contributions is the role that the estate and the infrastructure plays in supporting high quality infection control, whether that's through ventilation, whether it's through appropriate PPE provision. Now, obviously, my particular area of focus would be on hand and surface hygiene provision, and I think that's the case there too. One of the things that we certainly learned through the pandemic was that, as I mentioned earlier, there was an initial supply chain crunch, of course, as everyone can remember. And solving that, I think, was much more than just making alcohol-based hand rub available. And I think what we learned, or actually I'd say what we relearned, was how important it is that those products are not only available, but they're available in the right locations at the right times, that they are accompanied by signage, by educational provision, by prompts and cues. Make sure that we really support healthcare workers to carry out hand hygiene and surface hygiene in the right ways at the right times. And I think what we saw through the pandemic was those early stages where lots of new manufacturers came into the market, and that's fantastic. That's fantastic that there was a real call to arms. But it's more than just providing alcohol. It's really making sure it's where you need it, when you need it, and those cues are there. And then,
But
if I may,
Sorry,
Helen, go ahead.
Maximum compliance as well. I mean, how do you make sure that, what should estates and facility professionals be doing to make sure that there's maximum compliance?
Yeah, absolutely. I think it's really about working with manufacturers such as ourselves and really thinking in that infrastructure way. So thinking that the supply of hygiene products is really about working together to identify with the infection control teams, where do they need to be, in what format, and how do they need to be cued and prompted to make that behavioral change or that behavioral adaptation as easy as possible. And I think the other piece I was going to mention was, again, specific to COVID. Of course, and again, it's not my area of expertise, but ventilation, mask wearing, glove wearing, all really, really vital and important. And of course, I think what we understood in COVID was that we're dealing with clearly an airborne respiratory infection, where the role that the healthcare worker is playing is, I think, quite distinctly different from the role that healthcare workers might play in the transmission of other bacterial-based healthcare acquired infections, where in that case, the healthcare worker is the vector, but the healthcare worker isn't generally becoming infected themselves. Whereas, of course, with COVID, the risk is to the healthcare worker to become infected and then to transmit it on through other wards. And I think it's really important that we recognize that distinction, and therefore recognize that there's a distinction between protecting the healthcare worker, but then protecting patients from unintended vector transmission on the hands and surfaces, which is much more of a component where it's a bacterial infection, I think, that we're trying to tackle. And I'm sure everyone would agree that just because there's a focus on one of those things doesn't mean that the others have gone away. And I think it's important that we get that balance right.
Linda, you touched on ventilation. Katie's talked about a little bit about textiles. What other measures can we take to reduce the risk of infection, do you think, within our estate?
So my colleagues on this call have spoken about a range of measures, and for me, I like to think about IPC measures as a Swiss cheese model. So if you imagine layers of Swiss cheese with vaccination, hand hygiene, PPE, surface decontamination, if they're all separate, then one of them alone is never going to be effective. But if we join them together, we've got more chance of having barriers in between infection. So I would say, collectively, it's looking at a collective set of measures. So it's that Swiss cheese model, and we know that, you know, in each element, things may not always be 100% as we would like them, but actually having that bundle approach is what's really important. So one of my colleagues spoke about having the PPE in the right place, and that's so important. So throughout this pandemic, we've looked at people's behaviours, because we know that everybody wants to do the right thing. So we need to make it easy for them to do the right thing all the time. And that's when we get the best outcomes for both staff and patients. And if I can just give a small example, we saw lots of used masks lying in the car park outside one of the hospitals. And we were like, well, you know, why would people not put them in the bin? Well, the bin wasn't in a convenient place for them. So as soon as we moved the bin, patients and visitors who were leaving the hospitals took them off and put them in the bin. So it's really simple measures, nudge behaviours, and theories like that really help with good IPC.
Katie, just going back to the domestic laundering of nurses' uniforms and you know, the risks and stuff, what was the knowledge and attitudes of behaviour of the nurses towards taking those uniforms home and laundering them during the pandemic? Were they quite willing to do that? Did they feel that was the best way forward, or was the pressure to have them laundered at hospital?
We did a big survey, which we did through a lot of the nursing societies, advertised it through nursing societies, and this was, all the peaks blur into one, but I think it was at the beginning of towards the end of the first one, and we had about nearly 1,400 nurses respond within a few days, which is actually quite a big response rate so quickly. So it was obviously something that the nurses were interested in. And basically what come out of that, there was a number of things that come out of that. One was they would prefer their employer to launder their uniforms, and that either on-site facilities or externally washed at an industrial launderers. And the other things that come out of it was the cost to them, because they felt having to do the high temperature, the 60 degrees, as Michael mentioned, that's in the policies, as well as individually laundering their uniforms with no other items of clothing. It was the cost and environmental impact associated with that, which some nurses couldn't meet due to financial constraints. And the other big thing that come out of it was changing facilities. The nurses were sort of okay if they could domestically wash them, if they could change on site and weren't having to get the bus, get in the car, go into their homes wearing the uniforms. But there was a lack of changing facilities, particularly I think they become a crunch when the pandemic hit, because everybody then wanted to change in the hospitals. And I know one particular hospital put like porta cabins in the car parks. There was more changing facilities, but some of the sort of hearsay that come out of that was they didn't want to use those because so many people going in and getting changed, and the virus could become airborne again by the changing, and then they were in and out. So that was one of the worries that they had then. So I think the nurses, as Linda said, wanted to do the right thing. They wanted to change on site and they wanted to be able to contain their uniforms, but the facilities that were available to them at the time were restricting that in some instances.
Gosh, it's fascinating, isn't it? You know, while we as mere mortals are watching all this unfold, and you guys in the healthcare industry are doing an amazing job, those are things that just would never have crossed my mind, that as well as long shifts, you know, nurses and having to think about that kind of thing. My eyes are just sort of flicking over to the right-hand side because we've got a few questions in. James says there's no specific courses for infection control for contractors. Is there a suggestion that training course for contractors could be set up to enable contractors to better educate staff and the supply chain on infection control measures? I don't know whether, Linda, is that something you feel you comment on with
Yes,
contractors where you are in Salford?
I think that's a fantastic idea. What we did learn through this pandemic is there weren't enough people trained in specialist IPC. So we did actually here within the Greater Manchester region develop a training package aimed at all staff, and they can access it free of charge for the first year. And it just gives a really good broad understanding of how we can all help. We also do have an IPC training package which we tailor just to contractors. But you're absolutely right. You know, what this has taught us is to think beyond those hospital walls and think beyond our traditional staff groups, because everybody has a part to play and everybody wants to play a part in it because they feel that they can help. So I think that's a fantastic idea. We are hoping that the package that we developed will be available across the whole of the NHS within a short space of time.
Yeah, good idea to share. Michael, I was going to ask you about what's the greatest concern, air, water, or inanimate environment, but just thinking, did you have anything to add to that? You know, where you are in Malta, is there any training for people outside of the sort of, you know, like contractors outside of the main sort of cut and thrust of the healthcare process itself?
I mean, the way the system works here is probably where we differ quite substantially from the UK. So our reliance on contractor staff is mainly related to in the hospital to the cleaning and domestic area. So most of the areas where estates are involved is mainly in-house. So we do the training ourselves for that. But I see we're winding down. But I just wanted to raise one point following these brilliant interventions. And I think if there's one thing that I've learned in relation to estates is we need to really take on board the science of human factors engineering, where basically you engineer your systems in order to take into account the human factors. And as Linda was saying, you know, we had the same experience with the doffing procedures. Initially, major issues. We all you need to do is just move a table here, a bin there, you know, an area for the new PPEs, and you practically solve the problem. And that's something that we need to really get better in, both in infection prevention as well as in estates management. And that's a brilliant science that I would strongly recommend people, you know, to just have a look at and get some ideas from.
John, hands, face, space. Do you believe this is an adequate measure going into winter to minimise those infection rates?
Well, I think that, I mean, obviously hands, face, space, I think it's a great simple way of communicating a lot of information. I think that for a community communication to the general public, I think it's really good, actually, I have to say. And I think it's a great starting place for healthcare. But of course, healthcare is so much more than that, as we've talked about already. Infection prevention in healthcare is a professional activity, and it's so much more than. First of all, it's so much more than COVID, as we've talked about. Healthcare-acquired infections are many and varied, and the infection transmission pathways that exist in the healthcare setting are far more complex, as are the nature of the people, the patients in the healthcare setting that require different types of intervention. So I think it's a good starting place. But of course, there's the WHO 5 moments of hand hygiene, among other infection prevention protocols that must be followed. And I think one specific thing, if I can sort of return it to, if you like, my area of alcohol-based hand rubs, is of course I think the amount and duration of a hand hygiene event in the community, I think doesn't need to be controlled nearly as well as it does in the healthcare setting. Again, because we're dealing with a different range of pathogens. So understanding the 5 moments, understanding the 6 positions, understanding when and how to perform hand hygiene and other hygiene interventions, I think takes us beyond hand, face, and space. If I may, though, I just really want to come back to respond on that question from James, if you don't mind, Helen, because I think it was a great question, and I just completely agree with what Linda and Michael said, and only to add to it that I think in a way it's kind of, for me, what I'm thinking is a circularity here, in that before the pandemic, I think, you know, we of course focused a lot on infection prevention in healthcare, focusing working with the infection prevention teams. one of the things that we've done through the pandemic is start to take that education and that guidance out beyond healthcare to other facilities and other estates managers who really need it, in schools, in shopping centres, in airports, in workplaces. And of course, in many of those facilities, there is no infection prevention team. So we are dealing directly with the estates managers, the facility managers who are tasked to provide high. And it strikes me that having learned that, now coming back to answer this question in healthcare, absolutely, yes, that community really should be drawn in and become part of the solution around delivering the hygiene infrastructure and supporting the hygiene infrastructure that actually allows healthcare workers to do their job most effectively. So it's kind of interesting to sort of learn and completing the circle back to where we started.
Well, I'm just going to end, I think, on a question which I'm going to pose to Katie, actually, from Dana. Dana says, hi, I'm an IP&C nurse at the RUH in Bath. With regards to uniforms, fitted smart scrubs should be an option, which would decrease the risk of the cross-contamination from uniforms. Old hospitals are always at a disadvantage for modern healthcare delivery. Dana also says the healthcare workers are so stretched and so fatigued that we need to make IP&C easy to follow. Katie, do you just want to pick up on Dana's thoughts there?
No, I agree. If it was a standardised scrub that could be on-site industrial laundry, it used to be done. Years ago, most hospitals used to have laundries on-site, and that has changed over time with the domestic policy coming in. I think it comes back for one less thing for the healthcare workers to worry about. And I think we focus very much on hospitals here, but one area of particular concern for me is care homes.
Yeah.
And the laundering and all IPC and all the things that we've mentioned within care homes. We actually wrote some policy, was involved in a policy that was written for care homes. One small section was laundry, which obviously was the area that I was involved in, but about the facilities and how that laundry is carried through care homes and things like that. So scrubs is one option where it's industrial laundered. And I think the survey that we did on those attitudes and opinions and what the nurses felt really reflected maybe a need for greater education, which I know John has picked up on and that I'm heavily involved in schools and in hospital work, that actually it's the education around handling of laundry or just IPC in general, which we've spoken about, both within those healthcare environments as we see traditional hospitals, but also community nurses, care homes, etc.
We need to make sure, I suppose, as well, that there's a standard, a standard across best practice, because as James says, we deliver construction services for NHS Scotland, where we encounter differences on best practice and standards across the different, across the different health boards and hospitals. He's asking how you propose to define this across all the health boards, apart from the guidance outlined in the health technical memorandums. Linda, how do we make sure that everybody's sort of singing from the same hymn sheet, if you like?
So I think, we are well on the way with that. Again, there's been lots of stuff happening in the background. And the one positive thing about the pandemic is that it has managed to break down barriers and cut through red tape that would have otherwise taken us years. So for example, if you look at the Scottish system, they've got the National Infection Control Manual, which is a suite of national policies. And that's actually where the NHS is going. We will have national NHS policies for everybody so that they will be the same across the whole system. And that will be the same for things like uniform and workwear policy, hand hygiene, you name it. So there will be a national database of policies, which is absolute music to my ears, because why should something be different in a different hospital when essentially it's under the same organisation? So yeah, definite progress in that area.
That's right. And it's been lovely today that we've had Michael on as well, so that we can learn from what Malta's up to. We are out of time. It's been fantastic to talk to all of you today. As I said at the beginning, last panel of today and last panel of 2021. So thank you for being so generous with your time. And I do hope all of you will join us at a future event. We've still got lots more to talk about, I feel. So thank you to all of our panelists for an insightful and interesting conversation. And thanks to you too for taking part. We've had some great questions coming in throughout today. I've got through as many as I can, and they've been much appreciated. With that, we do draw to a close on a fantastic day of guests and delegates networking across our NHE365 platform. We've covered a whole breadth of challenges, opportunities, and discussed solutions as we've engaged with the topic of NHS estates. I'd like to thank all of our speakers and panellists who have taken the time out to share their expertise and their insights. As mentioned throughout, all of today's content will be available to view on demand within the platform at your leisure within the next 24 to 48 hours. And remember, our networking tools remain open year-round with an ever-growing community of registered innovators, including you. I look forward to seeing many of you back again for our event on NHS Backlog on the 17th of February. Please do share the word with your colleagues. We love to welcome new faces to the platform. Now, if you're a winner in our gamification challenge, the NHE team will be in touch to discuss your prize options. Separate to gamification, today's event, as you know, was CPD certified with 1 CPD point earned for every hour of live content watched. If you'd like your CPD certificate, then please email marketing@cognitivepublishing.com to request your certificate. Before we go, I'd like to extend a special thank you to our events team behind the scenes at National Health Executive who have put this event together. I'm not sure today whether they've been dressed as elves. They were last time we did one of these events in December, but they've been brilliant as always. And from me and everyone at NHE365, thank you for attending today and giving us your time and attention. I'll see you again, hopefully, at our next event. So all it remains for me to say is happy holidays and all the best for 2022. Thank you.